And here is your supplemental lecture for the nervous system. We know that the central nervous system consists of the brain and the spinal cord. We know that the brain has four regions: the cerebrum, diencephalon, brainstem, and the cerebellum. And each cerebral hemisphere is subdivided into the frontal, parietal, temporal, and occipital lobes. We know that the brain is a very vast network of interconnecting neurons, or the nerve cells, which consist of the cell bodies and their axons. And the axons are the single long fibers that conduct impulses to other parts of the nervous system. Now, the brain tissue itself can either be gray or white. The gray matter, which consists of aggregations of the neuronal cell bodies, and it rims the surfaces of the cerebral hemispheres, which forms the cerebral cortex. The white matter, which consists of neuronal axons, are coated in myelin. The myelin sheath itself is what gives it that white color and allows for the nerve impulses to travel more rapidly. So deeper in the brain, you have additional clusters of gray matter, and that includes the basal ganglia, which affect movement, the thalamus and the hypothalamus, and structures in the diencephalon. Now, the thalamus itself processes sensory impulses and relays them to the cerebral cortex. And the hypothalamus maintains homeostasis and regulates temperature, heart rate, and blood pressure. The hypothalamus affects the endocrine system and governs emotional behaviors such as anger and sexual desire. Hormones secreted in the hypothalamus act directly on the pituitary gland. The internal capsule is a white matter structure where myelinated fibers converge from all parts of the cerebral cortex and descend into the brainstem. The brainstem itself, which connects the upper part of the brain with the spinal cord, has three sections: the midbrain, the pons, and the medulla. So consciousness relies on the interaction between the intact cerebral hemispheres and a structure in the diencephalon and upper brain stem called the reticular activating system, or the arousal system. The cerebellum, which lies at the base of the brain, coordinates all movement and helps maintain the body in an upright space. So the spinal cord itself extends, like we said, from the brainstem to L1 to 2, and it contains the motor and sensory pathways that exit and enter the cord via the anterior and posterior nerve roots and the spinal and peripheral nerves. And these are then put into 5 segments. Cervical, C1 to 8, and 8 because of the nerve root. Thoracic, 1 to 12. Lumbar, 1 to 5. Sacral, S1 to 5, and then coccygeal. Now, it's important to note that from the lumbar and sacral roots, those travel the longest intraspinal distance, and then they'll fan out like a horse's tail at L1 and L2. That's where the term cauda equina comes from. So we know that the spinal cord itself ends at L1 and L2. So that means if you have to do a spinal tap, for example, or lumbar puncture, that'll be performed below that. So L3, L4, or 5 in those vertebral interspaces. The peripheral nervous system consists of both cranial nerves and peripheral nerves that project to the heart, visceral organs, skin, and limbs. It controls the somatic nervous system, which regulates muscle movements and responds to the sensations of touch and pain, and the autonomic nervous system that connects the internal organs and generates that autonomic reflex responses. The autonomic nervous system consists of the sympathetic nervous system, which helps mobilize organs and their functions during times of stress and arousal, and the parasympathetic nervous system, which conserves energy and resources during times of rest and relaxation. We know that we have 12 pairs of cranial nerves, and these emerge from the cranial vault through the skull foramina and canals to structures in the head and neck. We have them numbered in the Roman numerals. So, as you got to remember back to nursing school, it's still same thing here, is you have to know all 12 pairs of the cranial nerves, what their function is, and how to assess them. So we know that cranial nerves govern motor, sensory, and specialized functions, and each cranial nerve has a specific function to that. So not only do you need to know the numbers, the name, and the function, but also how to test each one. So make sure you know how to do that. And of course, there are multiple mnemonics and ways of remembering these 12 cranial nerves. Whatever works best for you is what you want to use. We know that we have 31 pairs of peripheral nerves that attach to the spinal cord. There's 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral, and 1 coccygeal. Each nerve has an anterior root, which contains the motor fibers, that's the ventral root, and then a posterior or dorsal root that contains the sensory fibers. So this is how we get our motor and sensory. And then we know that the anterior and posterior roots will merge to form a very short, less than 5 millimeters, into the spinal nerve. And spinal nerve fibers commingle with similar fibers from other levels to form the peripheral nerves. So with motor and sensory pathways, they are descending motor and ascending sensory. And then the dermatomes, these are pretty neat. These are a band of skin that innervate by the sensory root of a single spinal nerve. So for example, if a patient was having, let's say, some numbness or tingling in, say, the thumb, you consider that there's a nerve issue at C6. Or if there's, say, numbness, tingling at the anterior tibia, you'll say that there's a potential issue at L5. So these are pretty neat in being able to assess potentially where there's any nervous system issues. When you're going into the health history, so some common or concerning symptoms are headaches, dizziness or vertigo, a feeling of generalized proximal or distal weakness, any numbness or abnormal loss of sensations, of course loss of function, consciousness, syncope or near syncope, seizures, or any tremors or involuntary movements. Headaches are quite an interesting and sometimes difficult to treat and to find the cause itself, because we know that primary headaches include migraines, tension, cluster, and chronic daily headaches. Secondary headaches arise from underlying structural, systemic, or infectious causes and may be life-threatening. In terms of health promotion and counseling, you want to, of course, prevent strokes or the mini strokes, transient ischemic attacks, TIAs. You want to reduce the risk of peripheral neuropathy, and then detect the 3 Ds: delirium, dementia, and depression. Moving along to the key principles when you're assessing the nervous system, questions you want to ask yourself: is the mental status intact? And of course, you can go back to the Behavior and Mental Status supplemental lecture, or of course, read it in your book. Are the findings that you're having, are they symmetric? So do the right-sided findings match the left-sided findings? If there's a lesion, so if your findings are asymmetric or they're abnormal, so is the lesion in the central nervous system? Does it involve the brain, the brainstem, or the spinal cord? Or in the peripheral nervous system, which might involve the 12 pairs of cranial nerves or the peripheral nerves itself. So you want to be able to organize your thinking into 5 categories: mental status, speech and language, cranial nerves, motor and sensory system, and reflexes. So again, we know mental status, going back to the Behavior and Mental Status chapter, looking through the cranial nerves 1 through 12, looking at motor system, the muscle bulk, tone, and strength, coordination, gait, and stance, sensory system, pain and temperature, position and vibration, light touch and discrimination, and then our deep tendon, abdominal, and plantar reflexes. So you do want to remember to learn the 12 cranial nerves and how to assess each one. We know that cranial nerve 1 is olfactory, and that deals with smell. Cranial nerve 2 is visual acuity, visual fields and ocular fundi. 2 and 3 is pupillary reactions. 3, 4, and 6 are extraocular movements. 5 is the corneal reflexes. Facial sensation and jaw movements. 7 is facial movements. 8 is hearing. 9 and 10 is swallowing and rising of the palate and the gag reflex. 5, 7, 10, and 12 are voice and speech. 11 is shoulder and neck movements, and 12 is also tongue symmetry and position. So again, make sure that you know how to assess each one. With the motor system, we're looking at position, movement, muscle bulk, and tone. So you want to observe the body position and any involuntary movements, such as any tremors or tics. You want to inspect muscle bulk and then note if there's any muscle atrophy. So by inspecting the size and contours of the muscles, do they look flat or concave, which would be suggest atrophy? And if so, is the process unilateral or is it bilateral? And is it proximal or is it distal? These are the questions you want to ask as you're going through these. We know that hypertrophy is an increase in bulk with a proportional strength, whereas increase in bulk with diminished strength is called pseudohypertrophy, which is seen in Duchenne form of muscular dystrophy. When it comes to muscle strength, it's graded on a 0 to 5 scale, where 0 there's no muscular contraction detected. 1, a barely detectable flicker or trace of contraction. 2 is active movement of the body part with gravity elimination. 3 is active movement against gravity. 4 is active movement against gravity and some resistance. And 5 is active movement against full resistance without any evident fatigue. And this is what we consider normal muscle strength. So asking the patient to move against your opposing resistance would be a grade 5 if the patient can overcome that opposing movement. Now, if a patient can only move against gravity, then you would assign a grade 3, for example. And your book does outline how to do each of these. So to test biceps and triceps of the wrist, you do flexion and extension, hand grip and the finger grip, abduction and adduction of the thumb, trunk, flexion, extension, lateral bending, thorax, expansion, diaphragmatic excursion during respiration, hip, flexion, extension, abduction, and adduction, and the knee and ankle, looking at flexion and extension. So if you have already gone through the musculoskeletal exam, these would sound awfully familiar. To test coordination, you can do rapid alternating movements, and that's having the person turn their hands back and forth on their thigh, for example, or you can have them tap the ball of their foot rapidly on your hand. In cerebellar disease, one movement cannot be followed quickly by its opposite, and movements are slow, irregular, and clumsy. This abnormality is called dysdiokinesis, and upper motor neuron weakness and basal ganglia disease may also impair rapid alternating movements, but not in the same manner. You can also do point-to-point movements, and this is where you can have the patient touch their nose and then say your index finger as you move it in different positions. You can have the patient move their heel from the opposite knee down the shin to the big toe. If they're, again, in cerebellar diseases, movements are clumsy, unsteady, and inappropriately varying in their speed, force, and direction. The finger may initially overshoot its mark, but finally reaches it fairly well. That term is dysmetria. An intention tremor may appear towards the end of movement. Moving on with the cerebellar diseases can also cause incoordination that worsens with eyes closed. So if this is present, you could suggest a loss of position to sense, or a sense of position rather. Repetitive and consistent deviation to one side, referred to as past pointing, which, if it's worse with the eyes closed, would suggest a cerebellar or vestibular disease. You want to ask, you assess the patient in their gait, so having them walk across the room, then walk heel to toe, and then walking on their toes, and then on their heels, and then hopping in place. So if there's any abnormalities in gait, that will of course increase the risk of falls. So a gait that lacks coordination with reeling and instability is called ataxic. Ataxia may be due to cerebellar disease, loss of positional sense, or intoxication. Tandem walking may reveal an obvious ataxia that would not be as obvious as doing the other forms of the gait assessment. And then walking on toes and heels may reveal distal muscular weakness in the legs. Any instability to the heel walk is a sensitive test to corticospinal tract damage. Here's a question. Coordination of muscle movements require that 4 areas of the nervous system function in an integrated way. Coordinating eye, head, and body movement applies to which of the nervous systems? Is it motor, cerebellar, vestibular, or sensory? And we know that the vestibular system, which deals with balancing and coordinating the eye, head, and body movements, whereas the motor system is muscle strength, cerebellar is rhythmic movements and steady posture, and sensory system is the position of the sense of position. I said that backwards twice. When you're assessing stance, you can do the Romberg test, and this having the patient stand with their feet together and eyes open with their eyes closed for 30 to 60 seconds without support. If there's any loss of balance here when the eyes are closed, this is considered a positive test. You can also do pronator drift and have the patient stand for about 20 to 30 seconds with both arms straight forward, the palms up and their eyes closed, and you can tap their arm briskly downward. If there's a pronating or downward drift of the arm, it's also considered a positive test. In cerebellar incoordination, the arms will return to its original position but overshoots and bounces. You want to, again, just general tips when assessing the nervous system, you're looking at symmetry. When testing pain, temperature, and touch, compare the distal with the proximal areas of the extremities, and this can help also with the dermatomes, knowing that. And then mapping out the boundaries of any area of sensory loss or hypersensitivity. When you're examining the sensory system to test pain, you can use a disposable object, and then you can do sharp. This is where we do sharp and dull, and then ask the patient to compare the two sensations. What I usually do is, when I have them feeling the sharp and the dull, I have their eyes open, so that also maintains our rapport in a form of trust. So I'm not sitting there poking them with something super sharp. They can actually be able to see what I'm poking them with. You want to test light touch using like a cotton ball. Testing vibration, you're going to use the tuning fork, and you can do it at the bony areas, so the DIP joint, and then you can even do it over the big toe, and asking them, do they feel a vibration or do they feel a buzz, and then having them tell you when it stops. Testing proprioception, you're going to hold the big toe by its sides between your thumb and index finger and pull it away from the other toes, and then move it up and down, and you can ask the patient to identify the direction of the movement. When you're assessing discriminative sensation, this is the ability of the sensory cortex to analyze and interpret sensations. Stereognosis, you'll place a familiar object, most commonly talking about, usually use it with a key, and put it in the patient's hand and ask them to identify it. Of course, this is without them looking at it. So astereognosis refers to the inability to recognize objects placed in the hand. You can have them do number identification, or graphesthesia. And this is, you can outline a large number in the patient's palm and ask the patient to identify the number. In the book, it almost looks like they're writing on the patient's hand. You're not writing in the patient's hand. You're just using your finger, or you can use the end of a pen to do a large number. And if they have an inability to recognize the number, then this suggests a lesion in the sensory cortex. You can also do two-point discrimination by using two ends of an open paperclip or two pins. Then you want to touch the finger pad in two different places at the same time, and if they asking the patient if they can identify one or two touches. Here again, just be careful, you do not want to cause pain. Any lesions in the sensory cortex increase the distance between the two recognizable points. You can do point localization by lightly touching a point on the patient's skin and asking the patient to point to that same spot. Any lesions of the sensory cortex will impair the ability to localize points accurately. Assessing for extinction, you'll have the patient touch an area, or you'll touch an area on both sides of the body at the same time and ask if the patient feels one or two spots. So again, with any lesions of the sensory cortex, only one stimulus may be recognized, whereas the stimulus on the side opposite the damaged cortex is extinguished. When you're assessing deep tendon reflexes, of course you want to use the appropriate reflex hammer. You want to encourage the patient to relax. So this kind of helps position by positioning the limbs properly and symmetrically. I'm going to hold the reflex hammer loosely because it's more of a movement of the wrist. You want to strike the tendon with a brisk, direct movement with minimal force. Idea is we're not trying to hammer a nail into a piece of wood. You can always use reinforcement as necessary, and then you want to grade the responses. So sometimes if the patient can just relax on their own, great. If you need to use reinforcement, so for example, one of the common ones that I like to use, if I'm trying to do the deep tendon reflex of the knee, what I'll do is have the patient clench his or her teeth, maybe even squeeze one thigh with the opposite hand. If the leg reflexes are diminished or absent, you can have them reinforce them by asking the patient to lock fingers. So let's say left hand over right hand over left hand, locking the fingers and pulling one hand against the other, so in opposite directions. And then you can just tell the patient to just keep pulling. And before you do that, before you strike the tendon, so that what that's doing is it's reinforcing and almost diverting the patient's focus to another part of the body, which then would relax whatever tendon you're trying to look for. So when you're grading the responses, it's on a 4-point scale, whereas 0 is no response. 1+ is somewhat diminished, might be considered a low normal. A 2+, which is average and considered normal. If there's 3+, this will be brisker than average, but possibly, but not necessarily indicative of any type of disease. And 4+ is very brisk. It's considered hyperactive, and sometimes we'll have clonus, which is that rhythmic oscillations between flexion and extension. Hyperactive reflexes, or hyperreflexia, are seen in central nervous system lesions along the descending corticospinal tract. So you want to look for associated upper motor neuron findings of weakness, spasticity, or even a positive Babinski sign. Hypoactive or absent reflexes, hyporeflexia, are seen in diseases of the spinal nerve roots, spinal nerves, plexus or peripheral nerves. And here you want to look for associated findings in the lower motor unit disease, namely weakness, atrophy, and fasciculations. Here's a question. Which of the following statements regarding reinforcement when assessing reflexes is true? Used when reflexes are symmetrically hyperactive. This technique involves isometric contraction of other muscles. Supports the unsteady patient, or D, all of the above. And we know that this is B, techniques that involve isometric contraction of other muscles and used when reflexes are symmetrically diminished or absent. Deep tendon reflexes are associated with cord levels for each response will help localize any abnormalities. So if you're doing the bicep reflexes, that's C5 and 6. Triceps is C6 and 7. The supinator or brachioradialis is C5 and 6. The knee reflex is L2 to L4. An ankle reflex is primarily an S1. And we already spoke about clonus, and that's used with a 4+ grade, which usually can be elicited at the ankle. Cutaneous stimulation reflexes, again associated with cord levels. Abdominal reflexes is in the upper portion, so at T8 through 10, or the lower, which would be 10 to 12, T10 to 12. Plantar responses is L5 to S1, and the anal reflex is S2 to S4. Some special techniques is asteriexis, which is motor disturbance marked by intermittent lapses of an assumed posture as a result of intermittency of sustained contraction of groups of muscles. If the patient has meningeal signs, that's dealing with the neck mobility, Brudinsky sign, and Koenig sign. And when you're assessing a stuporous or a comatose patient, a few things you want, always including your airway, breathing, and circulation. Being able to assess their level of consciousness, and there's a table on the next slide. Looking at pupillary response, ocular movements, and posture and muscle tone. So going back to this level of consciousness, so patient, you walk into a room, you're talking in a normal tone of voice. If the patient's alert, they'll be able to open their eyes, they'll look at you, and even track you throughout the room and respond fully and appropriately to any stimuli. If they're lethargic, you have to speak to the patient in a louder voice, so sometimes you have to call their name. Any lethargic patient will appear drowsy, but they will open their eyes and look at you, respond to questions, and then fall back asleep. If the patient's obtunded, you'll shake the patient gently, almost as if you're awakening a sleeper. And the example that I used in the behavior and mental status lecture, if you're having to wake up your teenager to try to get to school or your little one to get to school, an obtunded patient will open their eye and look at you, but the response is a lot slower and is somewhat confused. Their alertness and interest in the environment are then decreased. If a patient's in a stupor, you have to apply that painful stimulus, a lot of times that sternal rub. A stuporous patient will arouse from sleep only after the painful stimuli. Verbal responses are slower or even absent, and the patient lapses into an unresponsive state when the stimulus ceases. So you stop rubbing on their sternum, they won't respond. Now there's minimal awareness of self or the environment. Now if you're having to constantly repeat the painful stimuli, and this patient would be considered comatose, because they remain unarousable with their eyes closed. And there will be no evidence of response to inner need or external stimuli. So some don'ts when assessing a comatose patient. You don't dilate the pupils, the single most important clue to the underlying cause of the coma, because is it structural versus metabolic. And do not flex the neck if there is any question of trauma to the head or neck. You want to immobilize the C-spine and get an x-ray first to rule out any fractures of the cervical vertebra that could compress and damage the spinal cord. So you definitely want to be familiar with this table, and you also want to be familiar with the Glasgow Coma Scale, which is also in your book.